Between AI and ultrasound, Cynthia, I'm not sure what's next for you. No, I'm kidding. There's still a significant role, but I think that algorithm that you'll have may actually include intestinal ultrasound as a way to try and decide which patients will need future types of imaging depending on where the disease is located and whether there are complications, et cetera. So I'll walk you through sort of, as noted, I do believe it is changing. It's changed our practice at Mount Sinai, and for those who are integrated ultrasound into their practice on a day-to-day basis, they know what I mean when I'm about to explain how that's revolutionized our practice. So you mentioned the STRIDE-2 guidelines, and indeed, part of our journey was to be able to move from STRIDE-1, which was endo plus symptoms, to a point where now biomarkers, and Ben's going to update us on how we can use biomarkers to maybe optimize our treatment. Back in 2015, believe it or not, when we had the STRIDE-1 guidelines, CRP and Calpro was just to signal us to do MRs or colonoscopies. It wasn't thought that there was enough data in 2015 based on the systematic reviews that led to the guidance to say Calpro and CRP, if they're elevated, they accurately reflect an objective endoscopic or imaging outcome, and therefore you can use them to optimize. Well, in STRIDE-2, actually, that was the main difference, other than adding pediatric growth to that being a target in pediatric IBD, but the real change was adding biomarkers to be able to use that as a target of treatment optimization. So having said that, if you take probably the one study which said if you follow clinical symptoms alone or ignore clinical symptoms but use Calpro and CRP to drive you to escalate therapy from every other week adalimumab to weekly and or adding an immunomodulator, which is the CALM trial. And you could see here that even when you use objective biomarkers like Calpro and CRP, you still are less than 50% meeting the primary outcome of deep remission, using a CDIS score of less than 4 and no deep ulcers. So glass half full, glass half empty. And I don't know, Ben, whether you're going to talk about the fact that maybe we need a better biomarker for particularly small bowel Crohn's disease. Remember, 30–40% of patients may not even mount to CRP, and Calpro for ileal disease, I'm not so sure is as accurate as colonic, particularly left-sided. So the question is, do we need a better way of monitoring treatment responsiveness, imaging-wise, Cynthia already noted MRE being responsive, and whether or not we can take it to the bedside? And that's really where ultrasound comes into play, is how can we make quick decisions early on in the treatment, like CRP and Calpro, but use something at the bedside right there and then that you can make decisions without needing them to go get a poop test, needing them to drink contrast and be in a scanner, but be able to, within 5 minutes, be able to make a decision based on what your ultrasound looks like. So the idea being is that if we didn't achieve mucosal healing by monitoring not just symptoms, but also biomarkers, where do we fall short? And should we be moving to other ways or biomarkers of being able to monitor and keep people under tight control? And so the question really is whether or not, and I truly say not just because he's my mentee, but Mike Dollinger literally changing the way we practice inflammatory bowel disease by evangelically training everybody across the country who's interested. And every 2 weeks I have a new visitor to the IBD Center training. It's kind of fun, having people from all over the country come and sort of take part in how we integrate ultrasound into our day-to-day practice. So again, there are limitations which I'll note in just a minute, but essentially, as you get used to it, understanding that it has actually very strong visualization of the colon, with the exception of the rectum, so starting in the sigmoid colon all the way over, and then really just in the distal terminal ileum. It has a limitation in that you can't see jejunal disease typically, you can't see the rectum. Obviously, they are looking at using some probes that you may be able to use, and if patients are willing to do it in the clinic, some patients are accepting to have their rectum looked at in the clinic using a different kind of probe. But essentially, at the end of the day, you're able to visualize the key elements of what you need to make decisions, right? This is what it's about. It's about really being able to make in real time, and I'll show you the images. I'm spatially challenged, but even I could actually visualize what we call the Oreo, which is black, white, black, white. I'll show that to you in a minute. I'm sure that breaks your heart that that's as simple as we call it, basically based on colors. But essentially, here is what I mean, is that this is the lumen, this little sort of grayish, whitish area, the interface of the deep mucosa. The submucosa, you spend a lot of time, and that is a big marker for ultrasound as well in the clinic, is the submucosa. And then you have the muscularis, and then you have the serosa. So it's black, white, essentially that's in that cross-sectional. And you could see it longitudinally here, schmutz in the middle, then you have a black, white, white. Serosa lights up quite a bit here. But this is essentially what you're looking at if you're sitting there and looking at someone doing an ultrasound. You're looking at those 4 layers to the bowel wall. So again, very helpful at the terminal ileum, very helpful in the sigmoid colon, transverse, and right colon, limited as noted in the rectum. The left flexure can sometimes be difficult to find or get around. Obviously, upper tract is not the purpose of doing the intestinal ultrasound, and as I noted, more proximal small bowel disease. What are the 2 measures we look at? So we look at as being the dominant predictors of response, and I'll walk you through what the data proposes, but it's not that too dissimilar to what you just heard around MR. Bowel wall thickness greater than 3 millimeters, so we use the same bowel wall thickness and bowel wall hyperemia without contrast. So this is the ability to actually see hyperemia through Doppler. And I'll show you what that looks like as well. So our view of hyperemia is the Doppler activity and the bowel wall thickness the same, proximal dilation above 3 centimeters. It's the same guidance that we use for MR. So we're trained on how to read them, also length of segment. And these are the other aspects of ultrasound, but at the end of the day, although there's, talk about your 20 scores, there's like 7 scores now trying to like integrate all these various markers. And guess what they have all in common? Bowel wall thickness, and hyperemia. And at the end of the day, if you learn those, that's all you need, because that's really what predicts responsiveness to treatment and helps you make your decision making. So here's an example of thickness. You could see the black, white. Here's this very thickened submucosa here. So this is a thickened terminal ileum. Normally it's 3 millimeters, the same as noted, or less than. Here is Doppler. So this is the hyperemia. 0 is no signal. You see to see a score of 1, so it's a modified Limburg score. Here you can see a 2. You start to see those more red and blue dots. That's the Doppler activity, and then you could see a lot. And when you get a lot of Doppler activity in the submucosa, essentially the same as what we were noting on the MR, you know that that is significant inflammation. So this is how it's scored for bowel wall hyperemia and bowel wall thickness. Now, when you ask patients, and this is probably the most amazing thing about ultrasound, and I think Millie probably could agree, that when you are sitting there and you are showing patients what you are referring to in terms of this not being responsive or amazing, it's normal now, show them a previous image of what it looked like before while you are taking a history. It is an incredible moment to be able to share with the patient right then and there their improvement or why you believe they need to be escalated or whatever your dialogue, or stricturing, proximal dilation, why maybe surgery is the right answer. So a little bit of key elements that I just sort of highlighted from when you actually talk to patients and see their understanding. They understand more about their disease. It helped them understand where their symptoms are coming from, especially when you have a Crohn's patient who has a lot of functional abdominal pain, urgency, loose stools, and you're like, you know what, just come in, let's put a probe, because you know your Calpro is normal and you know your CRP is normal, and you scoped them 3 months ago and it was normal. Come on in, get on the table, let's look at your ileum, let's look at the area, make sure that you're not flaring. Again, there is a very important seeing is believing concept without an endoscopy and without going through MRE, and also in patients who you're worried about progression of disease. Did they go from rectal to now are they left-sided? Are their symptoms out of proportion to what you just saw endoscopically and or imaging in the past? So it allows you to really have a in-the-moment dialogue around the symptoms that the patient is experiencing right there and then. Now, it's important for us, just like with MRE, to make sure that we understand that they all line up. And when it comes to the terminal ileum and the sigmoid colon, I'd even venture to say that ultrasound is even more sharp for colonic disease, to be fair, when you actually line them up and look at MRE versus IUS in terms of colonic, particularly sigmoid inflammation. But this is an example just to show you across the board. You've got this segment of TI, you've got the MR findings, and you've got endoscopic findings, right? So they all match up, just like what Cynthia showed, that the MR and the endoscopy do match up quite nicely. The same could be said about intestinal ultrasound. And when they did look at, and there's been not infrequent ways of looking at prospectively actually looking at the correlation between intestinal ultrasound and MR enterography, particularly for ileal disease. Again, I'm not making any mention about anything proximal in the jejunum or proximal disease. Really, that's where you do need sort of full body abdominal imaging, and the ultrasound is definitely limited beyond the distal 20 centimeters, probably. When the ileum may drop into the pelvis, it may be hard or difficult to see. But there is quite a nice correlation between the two for detecting ileal inflammation. And this is where I was noting that when it came to endoscopy and then looking even at the Maria score, which again may not be the only way, and it's complicated and it's difficult to measure and it is not in your clinic. And my radiologists are not putting a Maria score in their reports. And so when it came to ileal disease, it was quite similar, but I will tell you from a colonic correlation, it does appear that IUS is better for colonic disease. Again, that is using the Maria score, not necessarily the eyes of our very talented abdominal imaging folks. So also, when it comes to other questions about inter-observer, because part of it is, I remember when patients ask, can I just get an MRE locally? I'd be like, no, I want you to come to Sinai. It was just, it was just this thing about being at a place that really has the expertise, the technology, and the technicians to actually understand how to do an MRE. And more importantly, our surgeons often don't believe, sometimes outside imaging, or particularly for pelvic disease, they didn't go low enough to be able to comment on perianal. It's just, there's a lot when you're not at an IBD sort of focused radiology center. And it looks like when they looked at inter-observer variability, there was quite similar agreement or disagreement on inflammation. And so it doesn't look like there's that much variability, because a lot of people are concerned around the intraoperative or the operator of the probe, for example. But again, if we're sticking to bowel wall thickness and hyperemia, I think that if we keep it basic and we're just trying to make really high-end decisions about what to do with my patient next, I think that many of us are able to learn that. Remember, in Europe, ultrasound is part of their fellowship. That is why intestinal ultrasound is part everywhere in Europe. That's what the gastroenterologists are doing. The fellows are training on it. And actually what's interesting is in Europe, though, they have separate abdominal pelvic ultrasonographers that are different than endoscopists, that are different than the clinicians. And they literally just do the ultrasounds, but they do entire abdominal ultrasound, liver, gallbladder. They don't just do. So it does take longer. But when you are focused only on IBD ultrasound, you get really good. Maya, this is Millie, this is your goal. You're going to do it in 3 minutes. It's like name that tune. I walk into Mike, I'm like, how quickly could you tell me what I need to do next? When you do 4,000 of them, which is how many Mike has already done, you're doing it in 3 to 5 minutes. It's really quick. You go to your sigmoid, you go to the ileum, you know where you need to go, you look, and you make a decision. And again, noting that one of the limitations is that we try and correlate things like a total MR score relative to our endoscopy scores. There is no total ultrasonographer score to correlate to an SCFCD score, for example. We can't be correlating things that are not, there's no total ultrasound score adding up the colon and the ileum like we do with endoscopy. And one of the most amazing things that I hope you'll take, anyone who's doing a clinical trial and doing ultrasound, will take this to your clinic on Monday. I will tell you that if you did an ultrasound before sending a patient to be eligible for a clinical trial, where the #1 reason for screen failure is the SCFCD is too low, you put a probe on that abdomen and you see activity, that patient is going to screen positive for a clinical trial. So it's quite amazing that we haven't even thought around other ways that we may be able to use ultrasound in those of us who do clinical trials, where the screen failure rate is 87% due to the SCSCD not meeting that criteria. You now have a way where you can say this patient has active inflammation in the TI, and more importantly, what Mike presented at DDW, and it's in revisions at the journal, is we wanted to see whether or not how accurate a change in the ultrasound score, a minimum bowel wall thickness is to correlate with what an SCSCD score is. So that does it match an inclusion criteria of SCSCD of at least 6 in any segment, or at least 4 in the terminal ileum? Because if we found what that look needs to be, we can send a lot more people to clinical trials. And that's what we did find, is we actually found that if you wanted to look at an SCS score when you wanted to see bowel wall thickness, as well as IUS scores, when we wanted to look at endoscopic remission, meaning an SCS-CD score of 2 or less, wasn't as fabulous. So an ultrasound so far may not reflect perfection. But what it did do is, underneath, what it did do for an SCS-CD score of greater than or at least 6 is if you have a bowel wall thickness, folks who are doing ultrasound of at least 3.6, you're basically almost 90% accurately going to predict that that patient would screen positive for a clinical trial. That's exciting for those of us who send the wrong people to get screened for clinical trials. But more importantly is the ileum, because you need an SCS-CD score of at least 4 in the ileum, and what we found similarly is if you have a bowel wall thickness of at least 3.6, you've got an SCS-CD score of at least 4. So it really will help those of us who have the ultrasound and also doing clinical trials. So it's another reason to start maybe considering bringing ultrasound in if you're a big clinical trial site, because it will actually improve the amount of patients you accurately send for clinical trials. Now, talked about responsiveness, same. Pre-induction, post-induction, you're able to see at anybody after 8 weeks or 12 weeks, whatever your induction period is, you're looking for a significant drop. Look at how thick that bowel wall is in terms of especially also the submucosa, and you could see here that it's thin, thin, thin. You don't have that thickness anymore, and you also have a significant reduction in the Doppler activity. This is actually outside of the bowel wall, this signal here. So this is what it would look like 8 weeks. They're coming for their first OBI for RIZA, or they're doing whatever you're seeing them, or their first sub-Q for ustekinumab, or whatever the reason you bring your patients in. You could actually now make a decision on escalation based on the ultrasound. So dose optimization, you guys are going to talk about whether we proactively optimize or whatever you're using other than PK. If you don't use drug levels, use an ultrasound. It should be able to tell you that you haven't been able to reach the outcome of interest to be able to improve the outcome of that patient. And really, one of the biggest issues that we've always had is how do you define ultrasound response? There was a call, a whole bunch of us got on, 25. We all sort of felt, yeah, if you get a 25% drop in your bowel wall thickness post-induction, that should probably be pretty good. It sounds the way we decided a 50% change in SCSCD. A whole bunch of us sat in a room and said, 50 sounds good. I mean, wouldn't we all want 50? Literally. So I say to you that this is how things are actually done, where you kind of bring so Sid, I apologize for you being such a strict scientist in epidemiology and clinical rigor. It doesn't always happen like that. It's sort of like, in your experience, what's sort of what you would like? Well, I would like about a 25% change in the ultrasound bowel wall thickness to go from 4 to 3. That's what I would like, or 6 to 4. So at the end of the day, there was a big consensus that we all sat on a call and decided that you want at least a 25% reduction in your bowel wall thickness to define response, and at least a 2 millimeter decrease. So if you were at 4, you would want to go to at least 2. If you were at 8, you would want to go to 6. It was sort of felt that that's where, based on some studies, and then some newer studies had come out after all of us were on a call, and it sort of said, you know what, you're putting your bar too high. That who's to say that you don't need less of a response in your ultrasound to actually say that someone's going to do well at a year? right? Like, why are we basing the 25%? That was using just like Calpro reduction of X or CRP reduction of Y before you decide you should optimize it. Sort of in the same vein is that maybe we need to test this. What do I really need to get from an ultrasound response before I feel it's going to predict what my treat to target is going to look like? So we did this work, and we actually did a prospective study where we looked and we did ultrasound at baseline, 8 weeks, 6 months, and at the time of the treat-to-target colonoscopy. And what we actually found is that with 0.995 for an AUC, which is really pretty good when it comes to actually accuracy, is that if you got a change of at least 18% at week 8 in anybody who's on an induction regimen, you actually got almost 100% prediction of what your treat-to-target scope was going to look like. And so maybe 25 was a little high. And the reason why I make note of that is I'm going to show you there's a study called the Stardust trial where they actually applied ultrasound as a secondary sort of analysis to look at using ultrasound in clinical trials to gauge responsiveness. And they used a 25% drop based on that consensus. And they didn't meet quite the outcomes that we wanted to in terms of its ability to predict what happened at week 48. And that's because we used too high a bar. So now we're starting to say that in clinical practice, just like Calpro, Ben, you'll tell us what Calpro we need to reach or what percentage change or what's an absolute. We're starting to declare what are some percentage changes in absolute we should be looking for. And it's not an absolute change of 2 millimeters. You just need a 1 millimeter change post-induction and an absolute bowel wall thickness less than 5.2 predicted endoscopic remission a year later. So it looks like almost a year later, 48 weeks later. And this is the Stardust study. So again, Stardust was the ustekinumab study with optimization and treat to target using endoscopy as a way to optimize your treatment. So this was using endoscopy earlier than week 52 allostride guidance. And this is showing you that overall, they were able to see the biggest drop in bowel wall thickness for everybody is going to happen in the first 8 weeks. If you do not reach an endpoint in 8 weeks, please optimize or switch. And we're starting to look at elastography a little bit. It's not as well established as it is in possibly the MR space, but there is a question about this balance between inflammation and collagen. Are we able to say that this patient would be better served with surgery, similar to what Cynthia was noting around there are elements on diffusion that may help you assume this is more fibrotic than inflammatory. So we're also trying to look at ways to be able to counsel patients who aren't meeting endpoints of interest in induction or after one optimization. Maybe we should go to the OR and not be pushing and switching drugs, but we can do that in real time without endoscopy in theory. That's sort of what we're hoping to achieve. And they looked at transmural healing. So transmural healing is indeed the future. And the question is it possible that we've done some kind of dent in surgery and Crohn's with biologics? Is it possible that if we went for transmural healing and not just mucosal healing, we would make more of a dent? And that's really what the proposed future is that we need to be looking transmurally, which is where we noted about MR enterography, but I would argue that if you can do it in 5 minutes at the bedside and make a decision faster than drinking contrast, glucagon, being on your stomach, being on your back, 45 minutes, patients will tell you that MR is not an easy test. If you've ever asked the patient, it is not the easiest test. Sometimes it's necessary and absolutely we need to use it, but the question is, can we have something that could get us to the same place, maybe faster and easier for patients? So again, that was just actually, I want to highlight the ileum versus the colon. I mentioned this morning around the fact that treatment responses are different between location. Similarly, you do not see as much of a response, interestingly, with ustekinumab. This is truly the study with Ustek. Again, I showed you risankizumab bowel location, and ileum is not as responsive and or doesn't look at the transmural healing rate between the colon and the ileum. And I said to you before that transmural progressive stricturing collagen deposition and bowel wall remodeling is definitely a problem for the ileum, much more than it is the colon. And that's why even you see transmural healing much superior in the colon to the ileum. That's with ustekinumab. And this was also looking at what happens to response. Same thing as clinical and endoscopic. The ultrasound tells you if you are naive to a biologic, you do better in your first drug. just the same. But when you start getting transmural healing, also it's 50% less if you had failed a TNF. So it's a very similar story endoscopically, IUS, and I'm sure MR, if the studies were done similarly in the same vein, using it in clinical trials. And we do know that transmural healing does reduce Crohn's disease progression, whether it's on MRE or intestinal ultrasound. So I do believe if we truly want to modify, not only do we have to do what we talked about this morning, which is personalizing and maybe using biology, but also understanding that this disease in Crohn's is more than a mucosal disease. It is a transmural process. How are we expecting to negate the surgical rates with some of our most advanced therapies, whether it be mono or in combo, whatever the future holds, unless we've achieved transmural healing? And we use it after surgery. So post-op, the anastomosis is one of the easiest things to see, actually, on IUS. And it's great because you could really see the anastomosis. You can see the small bowel becoming into the large bowel, and it's beautiful. So you could, instead of doing a post-op endoscopy in everybody, potentially, God forbid I'm saying that, but maybe you can look earlier at 3 months, 4 months to make a decision whether someone needs an endoscopy, and or someone who's elected not to do post-op treatment. Maybe you follow the ultrasound to be able to say, you know what, it looks like you're beginning to have some bowel wall thickness or some hyperemia, match it to the Calpro, which has been shown to be quite predictive of your post-op endoscopy, and use that to make some decisions. And what we actually showed is that with a really good AUC of 0.875, that if you have a bowel wall thickness greater than 3.2 post-op, it predicts a Rutgers 2. Do you need an endoscopy if you have such great prediction of the bowel wall thickness at the anastomosis, predicting what I would see at the time of colonoscopy? Why am I waiting 6 months to make the decision when I can make it earlier, right? So these are the questions that really need to come into play now that we're trying to move things. McKenna, I mean, she should have touched your heart in everything she said, but what she said is time is important. And that's why I say, if we have something that could quicken or rapidity of us making decisions, why are we not doing that, right? Why are we not integrating into our practice? Now, IUS, amazing to detect response to therapies. You've got severe ulcerative colitis patients, acute severe UC. You want to be able to look at whether endoscopy could be replaced in an acute scenario to be able to tell you that your drug is working. This was actually 2 DDWs ago, so already from the Europeans. Again, they've been using this much longer, and what they basically showed is that if you have a Mayo score of 0, your bowel wall thickness is about 2.8 millimeters. We talked about 3 or less is normal. So essentially, I don't need to rescope somebody. I could put them on the table, I can do an ultrasound and say, yep, you're responding to treatment, carry on, or not. Also, we're already seeing, this is a patient that already, if you have a severe, Ben did amazing work with pharmacokinetics in the acute severe hospitalized patient. We have a portable machine every day. We ultrasound this patient to look whether or not they need to go to colectomy. It's changed our practice in the acute severe UC. And so you could see change within a day. You will see hyperemia change. You will see bowel wall thickness already change. You'll see some stratification, some mucosal changes. And also at GDW this year, there was a publication from the Australians where they actually did an ultrasound on day 3 and were able to predict who was walking out of the hospital. And so the ability to show a change early, it's sort of like doing CMV check on day 3 with your Flexig. I'm sorry, you could probably negate that. If you're really worried about CMV, of course. But if you really just want to know whether or not the patient's going to walk out without needing advanced therapy or a colectomy, you can put an ultrasound probe on them. Pregnancy, change the way we monitor our pregnancy practice. So women, you're not scoping women, or you're trying to avoid MRs, for example, or IV contrast. You're trying to avoid any kind of invasive type of procedure, obviously. Imagine being able to actually detect inflammation, be able to monitor moms, very anxious around the impact of inflammation on outcomes. So you can see up to about 30 weeks, in many women, you could still see the TI in the sigmoid colon, believe it or not. So this is my plea to all, is that Stride 3 is going to integrate transmural healing, whether it's through MR or whether it's through IUS. But if we are going to change the natural history of the disease, not only do we have to personalize, as I noted, but we also have to achieve transmural inflammation, particularly in Crohn's. But I would venture to tell you we've completely missed the boat on UC, and UC is indeed a transmural disease. And chronic rectal inflammation and fibrotic and non-compliance, that's all a transmural process. And so again, we're underestimating because we haven't looked. But I think the future in the US is bright. And the beauty is that we've now held two, so the ultrasound, just for anyone who's interested in getting involved, the Europeans have created the IBUS, which is the International Bowel Ultrasound Society. They sort of set the guidance. A lot of these responses were all derived through IBUS, et cetera. And they've been doing it for years. And Canadians have also. My first paper as a fellow was using Doppler, because in Canada we don't spend any money on healthcare, is we had to use ultrasound. We weren't using cross-sectional imaging. This is like, when it was snowing and you walked uphill without shoes. That's the era of when I trained. But the idea is that in Canada in particular, we weren't using a lot of cross-sectional imaging in the 90s. And my first paper with Ernie Seidman was using Doppler ultrasound in Crohn's disease. So it was kind of interesting, full circle, when we brought it to the US. But we had our first, there's 3 modules. Module 1 is basically hands-on puppet. And some puppets, and Millie came and did her module 1 in Chicago, though. The second one was in Chicago, and then the third one is in Los Angeles in March. I think APP should learn how to do ultrasound. I think this would be an incredible addition to your arsenal of tools. And essentially, I think that it's really important to understand that once you get module 1, we're working on getting everybody module 2, and module 3 is like a test. It's not really complicated, but module 2 means you have to do 40 ultrasounds in order to be certified by IBUS. You get that in about 2 days at Mount Sinai, so anyone who wants to come, we're hosting any of you who've done module 1. And the biggest question I get asked is, can I bill for it? How many RVUs? And do you make money? That's everybody's question. And guess what? All 3 are positive. You make RVUs, your facility, if you do it in a hospital setting, the facility fee, I don't know, Millie, if you do it in ambulatory or Article 28 space, but the facility fee is quite good. And it's 1 RVU for just the ultrasound, then you add almost another RVU for Doppler. So you're getting almost as much as what's a capsule read to, colonoscopy 3, I don't know, whatever the RVU is. It's not that far off. So don't let anyone tell you otherwise. And if you really want to know, we wrote a Bible that was published in American Journal of Gastro that tells you how to set it up, how to bill, how to make money. Thank you so much for your attention.